Welcome. CMN 572. This is Unit 4. I'm Dr. Townsend. I'm going to do a brief overview of lipids, chronic kidney disease, abnormal uterine bleeding, and puberty. This is going to be just an overview of the content, and we're going to do some questions and cases. Hopefully you'll find that helpful. I've already found out apparently you can hear me. If you have problems, please let me know throughout the lecture. If you'll just use your text box and type in, get my attention, that'd be great. We will have questions at the end if you need to, or you can post them in the forum, either way. We will record this lecture, so it will be available hopefully this afternoon. It may be tomorrow, and I'll post it in the forum for you. Hope all of you are doing well. I know there's a lot going on right now in the world, and I want to just be really conscious of your time, so I don't want to waste it. So we'll get going, and I'll do the best I can to watch the chat box. I'm going to stop sharing so I'll have more room here. And let's see. Okay, we have our first one. When you want to think about the first content we're going to go over is statins. Your 4 major statin benefit groups. You want to think about that. Ask yourself these 4 questions. Does your patient have a history of heart disease or ASCVD or stroke? And if yes, then you're going to want to place them on a high intensity statin. Okay. For the next question, if you have someone you want to go, is the LDL greater than 190 milligrams per deciliter? Do they have familial hyperlipidemia? These are people, this is what you're going to be thinking about. If so, then you're going to want them on a high intensity statin as well. The next group, you ask yourself the question, does this patient have diabetes? Are they 40 to 75 years of age with an LDL of 70 to 189 milligrams per deciliter without ASCVD? If that's the case, then you'll start a moderate intensity statin. If it's 4, then you go to, does the patient without diabetes or ASCVD have a global risk score of greater than 7.5 for primary prevention of risk assessment? Now with this, you're going to consider moderate to high intensity for patients who need LDL lowering, and consider adding a non-statin. You might need to consider a CALC score, a coronary artery calcium score. And with that, if it is 0, then you can look at withholding a statin and maybe rechecking them in 5 years. Now, you may need to recheck it sooner depending on what happens with the patient. But if it's higher than 0, 1 to 99, then you would start a statin. But if you have it much higher than that, obviously you're going to look to use a statin with them. Now, the caveat with this is if a person with a CALC score is 0, but they have a bad family history of a lot of cardiac issues, or they're a smoker, then they need to be encouraged to be on a statin. This is often used for people who are reluctant to take statins. You need to kind of give them a little nudge. They don't want to get there. It can be very helpful for that group, okay, because you will have those people. We've got to know exactly what ASCVD is. And most of us go, well, duh, we know what that is. Well, when you're thinking about that, think about somebody with acute coronary syndrome. We know obviously somebody who's had an MI, angina, if they've had, any kind of, if they've had a CABG, if they've had stents, you know, if they've got an aortic aneurysm, PAD, if they have TIAs, any of that. I mean, they meet the criteria. Now, you will have people who are very high risk, and those include multiple major ASCVD events or one major ASCVD event and multiple high-risk conditions. So know what those are. That's important. So make sure, okay, these are hints. Make sure that you know what ASCVD is and make sure you know what a high-risk person would be. Okay, so think about that. Okay, so if you've got a person and they've had an MI and they've had, say, a stroke, well, that's a high-risk person, a very high-risk person. So you're going to want, their goal is going to be to get their LDL C at 70. So just, you know, think about those kind of things when you're thinking practical ways of looking at this information. When we're thinking about statins, some real simple stuff. This is obviously in your information I've given you, but I just put it simply. Statins are no-no in pregnancy. There are, I think, a category X is if we still use that way of describing it, but you don't want a woman on a statin. And so if a lady is going, we need to be careful about this because people, women are older having children now, and they may have multiple comorbidities, and we may just kind of maybe not think about it. They've got cholesterol issues. Make sure we're thinking about this when we're doing our prescribing. They need to have a period of coming off the statin before considering getting pregnant if they want to become pregnant, or being on some form of contraception, so that a good reliable one, so you don't have that issue come up. So that's just kind of my little pearl or thing there. Shared decision making. This is important. You want to really talk to the patient. Allow them to have questions. Ask those questions. Make sure you've discussed stuff with the patient. Discuss the risk and benefits of a therapy so that they can make an informed decision. Because, you know, there are risks of being on statins, so acknowledge that. Make sure you've gone over the risk enhancers, that you know those. I mean, let's talk about those. You know, somebody with chronic kidney disease, we'll go over that more in a little bit. Some metabolic syndrome, like we talked about our ladies that may have had preeclampsia with pregnancy. Premature menopause, these women, you know, over 40, they're younger than 40 and they go through menopause. That's a risk enhancer. Inflammatory disease, this is very important. You might not typically link it together, but someone who's got rheumatoid arthritis or psoriasis or HIV, those are risk enhancers. So they need to know they're at increased risk and may need to be on a statin. You know, that kind of adds up for them. Ethnicity, South Asian ancestry, that is a risk enhancer. So be aware of this. Over on the right-hand side of your screen, not sure which way it'll be for y'all, but on the right-hand side, you'll see over there where you see the different statins listed, and you see the high intensity and the moderate intensity. This is important when you're looking at this. It's real important to know. So make sure you understand the percentages and how much LDL reduction is available with the different statins. Okay, as a group, that's like if it's moderate intensity, you get, you know, this amount of reduction. If it's high intensity, you know, you're going to be thinking it's going to be reduced by 50% or more. So make sure you understand that. Know the statins that are high intensity, know the ones that are moderate, know the dosages. Okay, so, you know, you've got atorvastatin, rosuvastatin. I mean, those are your high intensity. You know those dosages with that. Make sure you understand that. Okay, that's a hint. Okay, moving along. Monitoring after statins. pardon me, when we put a person on statin, now we need to get a baseline. What is their lipid panel? Now, the research and the recommendations, usually clinical practice follows a little bit, it lags behind. That's always kind of the norm. So you're going to get a baseline lipid panel, and you'll see out in practice that you'll probably get liver functions and, cholesterol panel. All right. Well, now everything's a little bit gray. It doesn't say you have to get the liver enzymes, but you'll still see that being done. Okay. It's probably maybe not a bad idea to get an ALT. In that particular liver function, if it's greater than 3 times normal, you're going to hold that statin. Okay. So just be aware of that. That's one of those things to know. But when you're thinking about the monitoring, be aware that you assess the lipid profile in 4 to 12 weeks after starting, and that can be fasting or non-fasting. And then you're going to reassess for adherence. We used to say whether they're being compliant. Are they even taking it? Because I will tell you, a lot of times people will get this and they'll never feel, and that's with any prescription. They never even feel it. But with statins, it's probably around half. So be aware of that a lot of people aren't even going to get it. And you're going to think they're on this medicine and they're really not. And maybe they've had an MI and they've had all these things, and you just assume because it's on their med list that they're taking it, and they're not. So, follow up, make sure that you're checking this, and have a real discussion with them, that shared decision making. What's going on there? What's happening? All right. So we will, when we think about statin intolerance, this is one of those things to discuss, because some of that, while we talked about people won't take it, maybe they have issues. Something comes up. They have pain, they have discomfort, whatever. They can have all kinds of problems. Make sure you're discussing it with them so you know what's happening with your patient. You may need to switch to a different statin, reduce the dose, or administration frequency. Sometimes you can go to a longer acting statin like a rosuvastatin or a atorvastatin. You might want to go to a hydrophilic statin like the rosuvastatin or pravastatin, because they might have less muscle aches with that. There's an app from American College of Cardiology. I think I put it in your in the forum that y'all can use, and that might be one that you might want to be familiar with, not for testing purposes, but just to have when you get out into clinical practice, because you will get these kind of tricky people, and you don't necessarily want to label them as statin intolerant. You might want to work through it and make sure, is that really what's going on or not? Did you tell them, okay, Mr. or Miss so-and-so, I need you to get healthy and get active and exercise, and you're going to do all this stuff. And so then you got them out there, and they're really believing, and they've been exercising and doing all this stuff. And maybe they're not having myalgias because of, the medicine. Maybe their muscles are hurting because they finally are no longer couch potatoes. So make sure you know what you're really doing. It should be generalized aches all over, those kind of things. And it'll be a prolonged period. So, look at that. And you'll get more familiar with that as you go along. Let's just go over a few questions. You've got a 50-year-old male patient with a history of type 2 diabetes and a history of a previous MI, and he presents to the clinic not on a statin. Based on this history, what statin option would be the most appropriate? So what are you going to put him on? Dawn says C. C, Janice, C. We got C going on. C, yay, y'all are winners. All right. Okay, Good. Let me see if I can get this thing to advance. Sometimes it's tricky. All right. All right. Excellent. C is the only high-intensity statin provided in the possible answers, and this patient needs a high-intensity statin based on the 2018 guidelines on the management of blood cholesterol in table 4. Exactly. Very good. Thank y'all. Y'all bear with me. Me and these allergies, it's pollen. My car is yellow, and that's not its natural color. Scary. So, all right. Lipids. All right, let's see. We got question 2. High intensity statins typically lower LDL levels by greater than or equal to 50%, between 30 to 49%, less than or equal to 30%. All right, looks like we've got an overwhelming A for the answer. Excellent. Some of y'all are getting with it. I'm proud of you. Very good. All right. We've got our lipid case. Now, I included this, and I want to say this with y'all. This is in preparation. Hopefully, y'all will find these helpful. They're meant to help prepare you for the final faculty evaluation, to kind of walk you through the thinking process, so you can have the different pieces to put this together. Obviously, you're not going to have quite all these different pieces on the test, but maybe that will help you when you're having your final faculty evaluations. So I hope you'll find this helpful. All right, we've got Mark. He's a 55-year-old white male with 5-year history of type 2 diabetes, hypertension, hyperlipidemia, and he presents today to establish care. The blood sugar runs 50 to 60, fasting when checked for 2 weeks. He's on metformin, 500 milligrams BID, lisinopril 10 milligrams Q-day, simvastatin 10 milligrams QHS. He smokes a half pack a day, no ETOH, occasionally takes the dogs for a short walk. Love that. All right. He is, and we have his vital signs, 148/92. His heart rate is 84. His height is 6 foot. He weighs 230. His BMI is 31.19. His total cholesterol is 210 milligrams per deciliter. His LDL-C is 135. His HDL is 35. Triglycerides are 330, and his A1C is 8. All right, this patient's current 10-year ASCVD risk is 37.6. What would your treatment advice be to reduce this patient's risk? This is going to be, as I said, a comprehensive plan that will most likely require more than one visit for this patient, because you got to get them to buy into this plan. All right. What would be your most appropriate next step? All right. Stop smoking. Start walking 30 minutes a day. Okay. Stop the statin. Okay. Increase the torvastatin. All right. There we go. All right. All right. So we're going to think about some of these things can be, now we're still on the lipids. All right. So some of these things are going to be stuff you can do in one visit. And I think that's mostly the takeaway with this, is that's what I want you to see with this. Not everything you can do can be done all in one visit, because sometimes the patient they just can't do everything. And they're going to look at this and they're going to see this 37 and they're going to be overwhelmed. Okay, so here's your options to your next step with this patient plan. Okay, you can increase the simvastatin to 10 milligrams, from 10 milligrams to 20 milligrams QHS. You can begin as ezetimibe Q-day. stop the simvastatin and begin rosuvastatin, 20 milligrams q.day, or start a PCSK9 inhibitor and get the patient to goal. What would you do next? Okay, who's going to do C? I got Lauren. All right. Very good. All right. C. All right. Now, and as I said, now you're not going to have one of these exactly like this on a test. This is more of one of these for, remember, for your final faculty face-to-face type of encounter. And you will have a plan to follow through, to work through with multiple things to do. Okay? So this is why I gave you options to select and that were framed here. But this is to help you think, what all do you have to do? Y'all are putting out all of these things that you want to address, which are all correct. So you're all thinking about this case in the proper way. So that's why I want you to be considering it. I'm very proud of the things I'm seeing coming across the screen. So this is good. All right, we're going to go through each one of these things. You want to change the patient from simvastatin 10 milligrams to a high intensity like rosuvastatin 20 milligrams. This drug is known to decrease the LDL-C by greater than or equal to 50%. In general, a moderate intensity statin would be indicated for diabetic, except when that diabetic, as in this case, has multiple ASCVD risk factors and is between 50 to 75 years of age. This should help this patient moving to his LDL goal of less than 70. With an ASCVD risk above 20, it is reasonable to add ezetimibe 10 milligrams at follow-up if his labs show LDL-C is still not at goal. Use a high-intensity statin in addition to lifestyle modifications, weight loss, begin DASH Mediterranean eating pattern, decrease saturated fats, and increase dietary fiber, and begin aerobic exercise plan, walking at least 150 minutes a week. We hope he'll do that, preferably more, and weight loss goals. Okay, so we hope we can get him there. A1C, it needs to be 7 or less. Your other labs were okay. So a simple option could be to increase his metformin to 1,000 milligrams BID. Plan to recheck his CMP with an EGFR in the next visit. Okay. Okay. As you start reading this, let me change 4 groups. Slide 2. How do we know who gets high and who gets moderate? As you start doing your reading, you will see more, you will be able to better pick that out. Who gets high, when you start looking at the risk factors, we can go over that more a little later, but that can take up quite a bit of time. The A1C for this one, like we said, would be 1,000. Hypertension, you back there when we talked about those risk factors, who was a high risk person, you have to go back and ask yourself, do they meet the very high risk? Yes or no. So you're going to go back and determine if they meet that to answer your question. Then you're going to look when you're scoring them, is that score over 20%? So those kind of things, you're looking at both of those things. So but if you have more questions, just please post it in the forum. I'm sorry, I'm losing my voice. I apologize to y'all. Let's see. For hypertension, currently they're on lisinopril 10. That would be more of a stage 2. So you would consider like lisinopril, increasing that, like lisinopril 20 milligrams. You may do with HCTZ 12.5. That's kind of an easy that you can do. And because since they're diabetic, you really kind of want to stay, provided they're not having any problems with the lisinopril option or an ACE option. With the elevated triglycerides, this should improve because the person already is, you've increased the statin, and if you can get them on board with some lifestyle modifications and weight loss, you know, hopefully, you may have to add on the fenofibrate, but that should be down the line, and hopefully you won't have to go there. But this is like one of those cases where you can kind of work through a lot of different options. So you can see. Now we're going to get this smoker, and we hope that he will stop smoking. But this goes back to that motivational interviewing, okay? Remember, we had all that stuff in 571, and so you're going to pull that out again, all right? And you're going to try to encourage them, but you got to see where they are. It's like with weight loss, it's like with everything. Trying to get them to that point. Are they ready to quit or not? Or are they ready to cut back? Even if they're ready to cut back, cheerleading them on. So you can try, you know, Chantix patches, whatever they're willing to do, you know, go for it. Aspirin, you know, there's a whole big controversy about aspirin. But according to the U.S. Preventive Services Task Force, this person should be on aspirin. So we can go with that. We do know that anybody with a heart attack or stroke definitely needs to be on an aspirin. So that's a, you know, that's one of those that we know those people need a low dose aspirin. So unless they have a history of GI bleed. So it's always one of those weighing out those risk benefits and having that shared decision making and discussing with that patient where they are, okay? So that's why we have this case, and there's a lot of different little wrinkles here to it, but hopefully this helps as y'all are thinking about it, and you can do some reading. I know we're going over this pretty early on in your having this information, but I wanted you to have it so y'all can have time then to post questions to me in the forum, and we can discuss stuff more if you need it. Okay, I put this, the ASCVD calculator with the percentages, and this is only just to let you know, sometimes when people get this, this percentage and it's just really high, and you're sitting there with the patient and it comes back at 45 and all these wild numbers, it freaks the patient out. And some people are seriously motivated and they're ready to go out and change their whole lifestyle and they're ready to do it. And then you have others and they're ready to give up. And you have to give them hope. And it is so imperative that you say, okay, let's work on this as a, you know, how can we attack this? We can do this together. And in saying to them, you know, maybe you can't do everything, but right here, all of a sudden, we've improved this thing because we're intensifying this blood pressure thing. Can we work on this? Yes, we can get this blood pressure under control. Can we walk some? Can we increase this? Okay, if we can't quit smoking, can we cut back a little bit? You know, if we're moving in the right direction, we're decreasing the risk. We're intensifying the statin. So we're bringing that risk down. So you can show them how the percentages are coming down, and that will make them feel better. And then that can give them hope to get more and more motivated. Okay, so I think that's important for us to give people hope, because sometimes when they see that, it looks like we've taken that hope away. And depending on what other factors are going on in their life, they may just feel like it's just insurmountable. So let's continue to be cheerleaders for our patients. Okay, let's move on to chronic kidney disease. All right, first off, let me just tell you, you do not have to know the statistics, okay? I do not expect you to memorize the statistics, so relax, you don't have to know that. I just wanted to put these on here to impress upon you the importance of chronic kidney disease. And I can't tell you the number of times, being a nurse practitioner for 22 years, that I have walked in and reviewed charts and records, and the person was pretty advanced with their chronic kidney disease and it had never been recorded. And it does impact how you prescribe for people. And I just can't say enough. Please, please, please be cognizant of this. And it can really get you into a lot of legal liability and other things. So watch what you're doing here. Okay, 15% of adults, 15% of US adults, so that's approximately 37 million people, have chronic kidney disease. Most of those percentage, 9 in 10 adults with CKD don't even know they have it. 1 in 2 people with very low kidney function are not on dialysis, and they don't even know they have it. Okay, so they're going to come into you and they're not going to know they have it. Okay, so they're just feeling really bad. CKD is more common in people age 65 years and older, more common in women than men, and more common in non-Hispanic Blacks. Okay, diabetes and hypertension are the 2 main causes. Okay, so that's important. All right, it's 1 in 3 adults with diabetes have chronic kidney disease. 1 in 5 adults with hypertension have chronic kidney disease. You know, every day you have 240 people placed on dialysis. You know, African Americans are more likely to be affected than whites. You know, you just have some numbers here. I do want to say a comment about children, because we don't really have a lot about that. In the US, children and adolescents younger than 18 years of age, polycystic kidney disease and glomerulonephritis, or the inflammation of the kidneys, are the main cause of end-stage kidney disease. Now you will see it said end-stage kidney disease and end-stage renal disease. You'll see both of those interchangeably, so be aware of that. But I just want to say that about the glomerulonephritis, because link that back to streptococcal infections or strep throats or upper respiratory infections that are caused by strep. If that's not adequately treated, that's causing problems with the kidney. It can. So be aware of that. We need to be doing our due diligence, okay? So you can tell I'm pretty passionate about this. So, you know, make sure, because you do not want to see kids on a renal transplant ward waiting for a kidney, okay? So let's, you know, try to be aware of that and do what we can. Let me just say that usually the EGFR at around 10 is where the nephrologist is going to set people up to be getting ready for dialysis. Okay, now you'll see stuff, and sometimes some, depending on the person and how they're doing, some will wait till they're 5 to 7, but you're really kind of pushing it there. Okay, most will get them ready about at 10. Okay, so that's when they're going to get them ready for hemodialysis, peritoneal dialysis, depending on what they're going with. All right, just so you know. All right, chronic kidney disease. The manage blood sugar, blood pressure. This is key, y'all. Encourage healthy lifestyle changes, dietary consult, create a kidney healthy eating plan. This is so important. You're not always going to have a nephrology dietitian, but if you do, wow, you really need to utilize them, because they can save your bacon. for, you know, helping you out a lot with these patients. And there are a lot of them that need this. These diabetic patients, your major heart control, hypertensive patients, etc. They can truly help you a lot if you have a good dietitian that can help them with this. But you know, on your consults, be specific with what you're wanting them to address, so they can work with the patient, and not just a general consult. As CKD gets worse, the plan may also include limiting their phosphorus and potassium. Use medications to help preserve kidney function. So, you know, you already know about ACE inhibitors and stuff like that. Stop smoking, which we've already kind of covered, and avoid conditions or exposures that can harm the kidney. This is really very important. And down here, certain medicines over the counter, people take a lot of stuff. You don't know what they're taking half the time, and they don't tell you because they don't think about it. Oh, I'm just taking these vitamins and herbs and whatever they got from the health food store. My goodness. But try to find them out, because it can be harmful to the kidneys. You know, ibuprofen, naproxen, very important to know that. You do not want to do that when people start getting chronic kidney disease. Can't say that enough. NSAIDs are not good for the kidneys. Some antibiotics can be very hard. One comes to mind all the time, Bactrim. We think about that, and I think about that, it's kind of ironic, and hopefully I'm not using the wrong word, but you know, Bactrim is used often for UTIs, and but it is not a friend to the kidney, you know, if somebody has poor renal function. You know, in an older person, that's a pearl. You need to be very careful using that, because they have diminished kidney function just in general. And so you give a good dose of Bactrim, you can shut those kidneys down. So be careful with that. All right. That's not a test question. That's just a little pearl. Proton pump inhibitors. Those are tough on the kidneys. So that's a medicine. We need to caution our patients. We have a lot of patients that are treated for GERD, and they take proton pump inhibitors like candy. So, you know, not that it's not helpful for what it's used, but there's a balancing act. So we need to make sure risk and benefits. We've discussed all this with the patient, and that they know that's that shared decision making. It continues on as we go forward, and make sure you're documenting it for legality purposes. All right. Certain contrast dyes, you know, we use these to make the vessels and the organs more visible for imaging studies. Make sure when you have someone who is usually going to have to get some lab work before they go to have these studies, but also think, do you really need those in people with chronic kidney disease? Or is there a different study you could do that wouldn't possibly harm the kidney? Can you just get a regular ultrasound or whatever? So ask yourself some of those questions. Kidney infections, you want to avoid those. I do want to say a little bit about diet, because you don't always have a wonderful dietitian that you can refer the person to. If you're out in the country or somewhere in a more rural, remote area, you may have to be doing some of that. Make sure, you know, with protein, you don't want them to be malnourished, but they do have to as the kidney disease advances. You want to limit that protein to 0.6 to 0.8 grams per kilogram. So we know that can slow the kidney function. So remember, like 0.6 to 0.8 amount of protein a day is usually preferred for someone with chronic kidney disease. Decrease the salt, no more than 2 grams daily, no more than 2 liters of fluid, or restrict the fluid, because you know they can get volume overload, so be careful with that. Their phosphorus and potassium, that's going to become a problem as the kidney disease advances. You know, when they start getting to stage 3, and as they advance further on into stage 3, more and more things start becoming a problem. So that's really kind of key, particularly with phosphorus. Tell them, avoid those processed foods. You know, they like to get everything out of a box. Avoid those processed foods, because that can be problematic, and sodas. All right, so those are kind of things to avoid. That's just an easy little thing to talk to them about, even though it may not do much good. Try. Chronic kidney disease worsens over time related to health problems. More of them become likely. You can get anemia or low red blood cell count. They can obviously have they can have fatigue and weakness. They get low calcium levels, high phosphorus levels in their blood. When it says bone problems, they're likely to have fractures. Just bottom line, they're going to have bone pain. They're going to have fractures. Okay, high potassium levels. They're likely to have arrhythmias. Okay, loss of appetite, nausea. These people, as their kidney function declines, they're going to feel bad. All right, extra fluid in the body. They get high blood pressure. They get swelling in their hands, feet, shortness of breath. I mean, they get heart failure. You know all that. Infections and weakened immune system. They're just a septic nightmare. They're septicemia waiting to happen. And so be aware of that. And they know that, and talk to them about hygiene and ways they can do to avoid or minimize the chance of infection. Because there are some things they can do. Just being very meticulous with their hygiene can help. Depression, obviously they're set up for being depressed. Their body is failing them, and they feel miserable because the toxins are building up in their blood and, going to their brain. They just feel awful. So, they're going to feel bad, and they feel depressed. They feel like they're letting their family and friends down. And it's just, and when they get to end-stage renal disease, they're having to spend forever, 3 times a week or so at dialysis. That's a major inconvenience maybe to their family or to them. And, when they're sitting there, that's pretty depressing at times. So be cognizant of that. That can be hard. I mean, when they're sitting there, sometimes people may code in the chair next to them. So be aware. That can be tough mentally. So we need to be really aware of that and supportive of our patients and try to avoid them ever getting to this point. Do our due diligence as providers to try to truly help them. I'm putting in my plug. I don't believe often that I think chronic kidney disease is a wonderful topic that those of you who are in the DNP program, you may are on track for that. I believe it's a great topic and would like to see more people consider doing something, a project related to chronic kidney disease. I don't think it's something that we do enough of, and it's a huge problem in this country. Moving on. First question. A patient presents with a diagnosis of chronic kidney disease. The lab returns an EGFR as 25 milliliters a minute. The patient is currently at what stage of CKD? Okay, we have C, stage 4. And the stage 4 C wins. We don't have a prize. Sorry, that's not the one you want to win. But yes, y'all are correct. All right, we have question 2. Your patient has an EGFR of 29 and is concerned about her dietary intake of protein. What is the best plan for this patient? Select the best answer. No dietary changes are needed at the EGFR. The CKD patient needs large amounts of protein a day to help the kidneys work better. Keep protein level at 10 kilograms per day. Keep protein at 0.8 kilograms per day and refer to dietitian to assist with renal diet. All right, looks like everybody has decided on D. Good. Now this one, I'm not trying to be insulting. This is one where hopefully some students have struggled in class. Not a lot, but it's always a learning with trying test taking. They are trying to look for the best answer. Okay, so this obviously D is the best answer. So make sure you read all of the questions and select the best answer. Don't get in a hurry when you're taking the test. You'll have plenty of time, and read all of the options available to you. All right, we got our first case with chronic kidney disease. Your patient has eGFR of 29 and is concerned about her dietary, let's see, we got 49, sorry. A 48-year-old man is referred to the clinic by his primary care provider after a recent eGFR of 55. Medical history of type 2 diabetes times 10 years, hypertension 5 years, medications, carvedilol 12.5 twice daily, lisinopril 20 milligrams daily, glipizide 5 milligrams daily. Recent labs, hemoglobin A1C is 8, potassium 4.5, MEQs, BMIs 23.29, blood pressure is 126/74. Other physical exams within normal limits. To prevent further decrease in patient's glomerular filtration rate, what are you going to do? What's the most appropriate thing to do? So what do you want to do with this person? Anybody? You want to do D? Anybody? E. Let's go back and look at this for a minute. All right. We've got, let's see, where is it? Okay, so we've got an elevated A1C on this person. Okay. All right. Increase the dose of glipizide, 10 milligrams. Because this person had, where was it? Yeah, he was fine. I think I might have changed some of this. The B could have been fine, or you could have increased the, you could have done either one. You could do that. Let me look. Place glipizide with metformin, or you could have done, yeah. eGFR is that, E. Okay. Probably done that. Okay. We'll do a B. Okay. we've got CKD, we've got this patient and he's not on a statin. What are you going to do? Does he need to be on one? Right. At least, you know, you can at least do a moderate intensity. You might do more than that, but you can at least do a moderate. You don't have a whole lot of information here to try to figure out, you know, what all, there's limited information as to try to figure out. You would have more in a real case, but at a minimum, you've got a diabetic, so you're going to put him on a moderate intensity to start things out with, and go from there. So, all right, let's go on to abnormal uterine bleeding. If his eGFR is less than 50, would you still give him a statin? Once he gets to more end stage, you don't start them on a statin, but if they're already on it and okay, you leave them alone. I believe that's more the general thinking. Hopefully I answered your question. Abnormal uterine bleeding. Okay. Sorry, I'm trying to look back and forth at the question and look at this. I apologize. Abnormal uterine bleeding. Let's see. We have maybe acute or chronic, defined as bleeding from the uterine corpus that is abnormal in regulatory volume, frequency, or duration, and occurs in the absence of pregnancy. All right, acute abnormal uterine bleeding is excessive bleeding that requires immediate intervention to prevent additional blood loss. All right, chronic refers to irregularities in the menstrual bleeding, usually from the previous 6 months. Okay, so the person's had some menstrual problem issues. Okay, and now the POM coin is the acronym provided by the International Federation of Obstetrics and Gynecology. And the first portion, the POM, describes the structural issues, and the second portion describes non-structural. And, you know, when we're looking at this, we think of how the issues that are related to abnormal uterine bleeding, what can be the possible causes. And, you know, it can be from polyps, adenomyolysis, leiomyomas, malignancy, hyperplasia, coagulopathy, ovulatory dysfunction, endometrial issues, iatrogenic, and not otherwise classified. You know, there can be all these little things. So the first thing we want to do, you know, the main objective for abnormal uterine bleeding, with acute, you want to control the current episode of heavy bleeding. Obviously, if they're hemorrhaging, you know, we all kind of know you got to stop the bleeding. You know, that's, everybody pretty much knows that. And then we want to think reduced menstrual flow with future cycles, you know, so that they're not miserable because they're having these horrible periods. So that's pretty much kind of the consistent thinking. Now, we're not going to go, this is beyond the scope of this lecture, to get into all the surgical management and things like that. We're just going to talk about, hormonal management. If they're bleeding very heavily, then they may get IV estrogen. That's beyond standard family practice fare. You're going to be looking at combined oral contraceptives for people pretty much in the chronic abnormal uterine bleeding domain. That's where we're focusing more. I did want to mention to you that you may encounter women with heavy menstrual bleeding, and a little bit of interesting statistics. Up to 13% of women with heavy menstrual bleeding have some variant of von Willebrand's disease, and up to 20% of women may have an underlying coagulation disorder. Now, you don't have to memorize that percentage. Tranexamic acid can be a viable option for women with heavy menstrual bleeding who might desire fertility. So, be aware of this. This percentage, this is just one of the things we were talking about with the Palm coin that could be a reason for the one of the issues was coagulopathy. And von Willebrand's and other women may have a factor type issue, and you can see that there can be issues up to 20% of women can have something there. But if a woman desires fertility, this can be an option, because we can't just put right. Thank you. Thanks for giving the brand name. That's very helpful. And we can't just, say we're going to put you on birth control pills and she's wanting to get pregnant. So, good. Janice, thank you. All right. Let's do abnormal uterine bleeding. Good. Primary cause of amenorrhea in adolescence is? Janice says C. Anyone else? Good. Wonderful. Right. Anovulation. All right. And then we've got the next one. When taking a menstrual history, it's important to inquire about the following. Select the best answer. All right. Fatima says E. Good. Correct. E is correct. This is one of them, I would say, again, make sure you're reading all of the options, because all of them are correct. So you want to select the best option, and that's E. Just one thing of note, please, I know you've heard this, I'm sure Professor Herf talked to you, make sure with childbearing age women that you're always getting a last menstrual period, and with any of them, and that is figuring into your treatment with any childbearing age woman, so that you are documenting that, because that can really get you into lots of trouble if you're not taking that into account as you're prescribing in their management plan. So we will move on. First, our case, you've got a 16-year-old female, G0, P0, presents to your office complaining of menstrual periods that last 10 days. Her cycles are irregular. Exam in the office is unremarkable. What would your treatment plan entail for this patient? What are you going to do for her? I want to get a pregnancy test. Consider oral. Okay. Gonna put her on birth control pills or think about that and a pregnancy test. That's not bad. All right. Anything else? Any other labs? Any other labs? Okay. Let's see what we might do. All right. Y'all are thinking right. Y'all are on the right track. All right. We're going now. This may vary depending on the history you get. So I'm just going to say that this is just in general. Sometimes you may have a little more narrow exam, and you may be able to tailor this more depending on the history you get from the patient. Okay, so it may be a whole lot more that you need to do or a lot less, just depending on what you're dealing with when you get a very detailed history. So this person, you want to check for a very vague, you don't really know at all what you're working with. You could get a pregnancy test, check for hypothyroidism potentially, CBC, PT, PTT. Remember, we had already talked about, do they have any anemia? Is that even a possibility? Because, how much are they really bleeding? Remember, we don't really know. We get some people have an idea of their idea of a period, and your idea of a period may be very different, whether it's heavy or not, and whether it's abnormal or not. So get them to really kind of quantify that for you as best they can. Try to nail that down. So, do they have any clotting kind of issues? So that's something to think of. The pelvic ultrasound, any structural abnormalities, probably not likely, but that can be something in the back of your mind. With this young lady, her pregnancy test was negative, yay. TSH was normal at 2.8. CBC was within normal limits, except for slightly low. And so we would, she might be a little anemic, nothing real exciting there with her. So, you could always consider an ultrasound later. Can ask them to quantify how many pads or tampons they saturate. That's an excellent point. And Janice, you're exactly right. Trying to get them to nail down the exam on her, yes. Does anything seem okay? When you're just looking at somebody, we'll get to that in a minute, but just try to find out what you're actually working with, because sometimes what they're telling you maybe isn't quite right. Some of them may have an app on their phone and they're keeping up with their periods, and really they can give you the good data, so that can be very helpful. So you can move along much quicker. So you see with this person, you got the menstrual history, and you did the physical, and you've got your baseline labs, and you did all this stuff, and the treatment of anemia, and you've gotten a lot of good information with this one. You want to treat their anemia with multivitamin, and maybe with iron included with that, and encourage iron-rich foods. Depending on whether they eat meat or not, you can encourage meat, but if not, the beans are also always good. Green leafy vegetables, raisins, foods with vitamin C to help it absorb better. You can always prescribe iron if needed, depending on how things go with the patient. And as we already indicated, putting them on a birth control pill is a good option. Most anovulatory anovulation in adolescence will self-resolve in 1 to 2 years after menarche. Once the hypothalamic pituitary ovarian axis matures, ultrasound or DNC may be required. The primary goal of anovulatory uterine bleeding treatment is to ensure regular shedding of the endometrium. Oral contraceptive pills can also be used as they suppress the endometrium and establish regular, predictable withdrawal cycles. Okay? All right, so we're going to just briefly touch on puberty in girls. This is a little bit of review, but just for this portion, just make sure you know, like, the average age. Menarche is around 12.5 years in the U.S. Signs of puberty is progressive breast development in girls, and no pubertal signs by 13 years of age, or no menarche by 16 is considered delayed. That's important. And so if by age 8 in Caucasians or 7 in Blacks or Hispanics, we want to be thinking there would be precocious puberty. Okay, so that's think about that. Boys, when we're thinking about puberty, we think of penile and testicular enlargement, and the average age when that starts is 10 to 12 years. Consider it delayed if no development by 14. Okay, so, you know, very important. I had a typo here. Precocious puberty, if no is, and I had put in the thing a correction. So if you made slides or you were looking at it, I'm sorry. Precocious puberty if secondary sex characteristics before age 9. I corrected it on my slides here, but if you have already gotten them, please correct yours. I just wanted to say, when we're thinking about like precocious puberty, sometimes these children, they may develop and be much larger than their peers initially, but often their adult height and stature will be compromised. So, or it can be. So just be aware of that, be cognizant of that. And also be aware psychologically, that can be very difficult for the child and the parent if they're on either end of the spectrum, whether they're having delayed or precocious puberty. So let's just be very sensitive when we're caring for these children and these parents and families. I did want to put one thing when we're talking about first thing to do for both delayed and precocious puberty is to check an x-ray of the bone age of the left hand and wrist. I think there was a question in the forum, somebody had asked, you know, why the left hand and wrist? Well, the best I've ever been able to find was that most people are right-handed, and so you're more likely to injure your right hand. So that's why it was just thought to uniformly go with the left so you get a standardized measurement. Also, back in the 1900s, very early, I believe I had read that, you know, at one of these major conferences, that it was thought that we should just go with the left hand. And so from then on, that has been the standard way to measure bone, you know, bone age. So sorry, that's the best I've got for you, but hopefully that helps, because I got that question and that's all I've ever been able to get. So I wanted to provide you with that. Primary hypogonadism, just girls, Turner syndrome, think about that. You get the missing X chromosome. Boys, Klinefelter syndrome, the extra X chromosome. When we're thinking about girls, with Turner syndrome, they will be usually shorter stature. You'll see the webbing of the neck. Boys with Klinefelter syndrome, tall, often with more smaller genitalia, very tall, long, lean looks. Hopefully, there's some descriptions of that, but I did want to just briefly mention that. There's more of that in your readings than on your video PowerPoint information. Just some tips for as you're preparing for this unit and the test. Be sure to do your reading in the unit. Make sure that you can answer the unit for questions to consider. Those, I think, will really help you. If you can do those, you should do well. If you can get through my 3 videos in the lesson section of the course, I am no videographer, so I apologize, but you know, that is what it is. There are accompanying PowerPoints for each that have the highlights, and if you have additional questions, please feel free to post them in the Unit 4 forum. And any questions now that I might can answer? I know this has been a long. If not, good luck. I hope this has been helpful. I wish you all safety, and please take care. If you have any questions, let me know. Please stay safe. Good luck with the exam. And if you have any questions, please feel free to post them in the forum. And be safe with this COVID-19. I wish you all well. Bye-bye. It should be available a little later today.